There is a possibility that patients do not improve within the first 3 weeks, that they may actually worsen after 3 days, or not improve after 7 days, or worsen at any time after that. And we define those patients glucocorticoid refractory. And in that case, at the first clinical observation of refractoriness, we determine that the patient needs a second agent. My impression is that early treatment, rather than waiting longer time, is actually beneficial for the patients with steroid refractory GVHD. There may be other patients that have an initial response, and then we're continuing the taper of the prednisone, and they actually have a flare. Those patients are defined steroid dependent. And although the flare may occur at a low dose of prednisone, invariably the outcome of such patients is so poor that I routinely start a salvage second agent line immediately at the time that I observe the first flare on prednisone taper. Those patients are said to be affected by steroid-dependent GVHD. Involvement with GVHD of visceral organ is associated with worse prognosis. And overall, grade 3 graft-versus-host disease is associated with about half the rate of response of overall grade 2 graft-versus-host disease that is milder and usually does not involve the visceral organ as much. For primary therapy, we use glucocorticoids, methylprednisolone, prednisone, or analogs. But once these agents fail, a variety of agents has been used because until recently there was no FDA-approved agent. The most commonly used agent is mycophenolate mofetil in the community. Personally, I prefer sirolimus, but recently I started to use sirolimus for GVHD prevention, and this precludes my use of the same drug for treatment. Fortunately, the recent trial and approval of ruxolitinib for treatment of acute GVHD resistant or dependent on glucocorticoids has changed our approach at treatment of steroid refractory GVHD, and that has become our standard of care second-line therapy.